of course, the issue of cardiovascular disease prevention in people with with diabetes in Africa. This is very important, as we all know, that an estimated 24 million people were living with diabetes in Africa in the year 2024, and it's predicted to increase to 55 million by the year 2045. Africa had the second lowest diabetes-related expenditure, accounting for only 1% of global diabetes-related expenditure. Again, we have more than half of people living with diabetes in the African region are undiagnosed. Only 36% of countries in the African region have essential medicines for chronic diseases in public hospitals, and this is the trend of heart failure in etiology in Africa. We can see that the main cause of heart failure is hypertensive heart disease. Then comes the cardiomyopathies, lesser are rheumatic heart disease, and the ischemic heart disease are just rising in this type of day. So it's a unique form of etiology for heart disease. What about hypertension and control? With the 27% of African are aware of hypertension status, 18% actually have on treatment, and only 7% are controlled. And are the deaths, as we can see, that's the cardiomyopathies comes first. And of course, what about the proportion of countries spending at least 5% of GDP on health? As we can see, the high income is spent around 97%, where we can see that in South Asia it's zero, and sub-Saharan Africa it is 45%. North Africa and Middle East will be 53%. So actually spending at least 55% of GDP on health is a little less in the African continent. We have modifiable risk factors that contribute to cardiovascular status, and this is the elevated LDL cholesterol, the high fasting plasma glucose. The air pollution is a very important risk factor. The obesity as well, tobacco use, the low physical activity, and we've heard a lot about low physical activity, the hypertension as well. So this is the key risk factors in African diabetes, main diabetics: the age, the body mass index, the uncontrolled the hypertension, the high triglycerides, the diabetes duration is really very important as well. And again, the urbanization-led diet shift. What about the cardiovascular risk in people with diabetes in Africa? Of course, it has bears the brunt of cardiovascular disease burden, and it has the highest risk of dying from non-communicable disease worldwide. But in Africa, there is an epidemiologic transition on the continent, where there is the non-communicable disease is projected to outpace the communicable diseases within the current decade. So there is unchecked increases in cardiovascular risk that contributed to the growing burden of the three major cardiovascular disease, hypertension, and cardiomyopathies. Again, the highest age standardized disability adjusted life years due to hypertensive heart disease is recorded in Africa. Hypertension is really very important. And we have a relatively rheumatic heart disease, a gradual decline, fortunately. Overall, it is also the African continent progressed toward a third reduction in premature mortality to come in the year 2030. And so definitely we are in the arena of effective policy implementation for the risk factor reduction and the cardiovascular disease prevention. So we have to invest, as we have said, in systematic country data collection, research outputs that will improve the accuracy and the burden of disease data, and inform policy adoption on intervention with potential to improve the current rate of progress toward achieving a 33% reduction in cardiovascular disease mortality. So this is, we have a lot of key policies to be implemented to address the cardiovascular disease. What about cardiovascular disease in diabetes? As we can see, this is a coronary vessel affecting the autonomic function, reduced heart rate variability as well. And again, we do have the cardiac muscle affecting the diastolic dysfunction, the systolic dysfunction. So we have a lot of different impact on diabetes on the heart, leading to vasoconstriction, inflammation, and thrombosis. We have very unique cardiovascular risk factors specific for diabetes. The microalbuminuria, the massive proteinuria, the abnormal platelet function, serum insulin is very important, the thrombotic ability and fibrinogen level. What about levels of prevention? We do have primordial prevention, we have primary, secondary, tertiary, and we have also quaternary prevention. So what is the difference between primary prevention and primordial? Are both public health strategies aimed to reduce the risk of disease. Primordial, you prevent the emergence of risk factor in the first place. You have to get your target groups, the entire population, the children and the adolescents, and you modify the broad determinants of health. The primary, you reduce existing risk factors to prevent the onset of the disease. And you have to target, it is not the population. You get the individuals at risk, but also who have not yet developed the disease. I will give you an MCQ telling you what is the most appropriate example of primary prevention in type 2 diabetic patients with no history of cardiovascular disease. So you have a patient, diabetic, type 2 diabetic patients. What is the most important step to get, example, to get a primary prevention? You just give him statins to reduce the cardiovascular risk in this patient. But which of the following is an example of primordial prevention, as I have said? To prevent cardiovascular disease in individuals for risk at diabetes, you just promote physical activity and healthy eating habits in school children, as my dear Professor Ines have stated in a very nice presentation about the school children and the need for prevention program. So driven by science and recent years and increased the focus on primordial prevention to promote health and reduce the population burden at risk factors. So definitely that cardiac disease is number one, even it's all over the world, despite the tremendous advancement in diagnostic and therapeutic tools, the physician experiences, the pharmacotherapy, the patient awareness is still one of the very important risk factors in Africa is the ambient air pollution, and this is really very important. And the cardiovascular health, as we have said, the primordial prevention is really important. There is a time for a paradigm shift, and look for the prevention, as I have said before, the population level, you look for the primordial prevention, primary individual level, you look for the primary prevention. So we have now in prevention what's called anti-inflammatory lifestyle. Anti-inflammatory lifestyle is a very updated element telling about exercise, quitting smoking, weight loss, stress management, treatment of depression, social support, and the anti-inflammatory diet, the healthy diet, also is again a very important new item. And the essential 8 of the American Heart Association, adding sleep, ample sleep, good sleep habits to the risk factors of heart disease, which is really very important. And of course we have to look our targets, as my dear Professor Ines have said, the preschool children, the school children, the young adults, take cheap healthy food, promoting desirable eating habits. Physical education is really very important as well. Again, we can prevent hypertension very importantly by looking for healthy habits, and really very important. At my end of presentation, Egypt had adopted a lot of policies, intervention, actions, and one of them was 100 million lives campaign, and really it targeted the non-communicable disease in a very nice manner. However, when we are talking about cardiovascular health, what is the real situation? We have only 0.1% of the participants had all components, only one are really definitely perfect at heart health. So, and 82% had poor cardiovascular health. So really we need a preventive program. So this is the comparison, very important. The cost is very important. We're talking about cost of health, and you can just you can have less money on cost for primordial when you are adopting a really a primordial prevention program. Fortunately, we can prevent mortality related to cardiovascular disease. We need that change. And my conclusion is diabetes is a priority disease that must be tackled to achieve the target. And definitely we need raising our public health insurance awareness. Again, the metabolic epidemic should be fought with inclusion of qualified diabetes educators, and the government has a real role. The Ministry of Health had the relevant authorities. And this is my last equation. I love it very much, and I think this is the key of healthy living. Zero. This was adopted by the European Society of Cardiology, and it's just said 0351 40530. This is a nice Alexandria phone number, very nice, saying zero for no tobacco. Walk 3 kilometers a day, take 5 portions of fruit and vegetables a day. Blood pressure should be kept at a normal level. Total cholesterol should be ample, and zero avoidance of overweight and diabetes. This is one of the workshop we did in the Egyptian Society of Cardiology to tackle the impact of prevention for diabetes and heart disease. And thank you very much.